the past, present and future of therapeutic innovations in osteoporosis. With increasing longevity, the aging population world over is increasing, and India is no exception. And one of the major problems of the elderly population is osteoporosis and its related issues. Osteoporosis is the most common bone disease in human. If you want to call it as a disease, it can be called as just a change because of the age and the lifestyle also. It is characterized by a low bone mass, microarchitectural deterioration of the bone, which you can see in this picture that the number of trabeculae go on reducing, which increases the bone fragility, and of course it increases the susceptibility to get the fracture. In India, it's one of the major public health problems, and to make it simple to understand, 1 in every 8 males and 1 in every 3 females over the age of 50 is suffering from osteoporosis in our country. If we compare it with the Western world, I think the age at which the Indian population is getting exposed to osteoporotic problems is almost 10 years younger to the Western population. As we are all aware, there are different causes of osteoporosis in addition to the age, the alcohol abuse, smoking, active or passive, vitamin D deficiency, which maybe I don't know whether to call it as little market driven, but then I think it has become so rampant in our country, wherein we were taught that this country is full of sunlight all throughout the year, and Indians don't face any problem of vitamin D deficiency because everyone gets adequate sunlight to manufacture one's own vitamin D. But then in today's practice, what we are seeing according to the standards which are told to us, more than 80 to 90% of our population, we are finding that they are deficient in vitamin D. Inadequate physical activity, which is becoming a problem of the younger generation because everybody is sitting on a computer. Hardly anyone right from the school days has time to go on the open grounds and do physical activity, and that has started affecting the population at a very younger age for this particular problem. Low calcium diet, the fast food that we are eating, I think there are so many things which are there as far as the food intake is concerned. I think we can just go on discussing about it for hours together. High salt intake, excessive thinness, excessive vitamin A, and immobilization. This is a flow chart which shows the pathogenesis of osteoporotic fractures. Low peak bone mass and the postmenopausal bone loss, the age-related bone loss, the nutrition causing low bone mass, the other risk factors, all put together, it makes the person osteoporotic and makes him or her more prone for developing porotic fractures. How do you diagnose? In addition to the clinical history that you take, you have to analyze the clinical risk factors for osteoporosis and the osteoporosis related fractures. You have to go systematically, you have to do physical examination after the history, you have to do BMD assessment, vertebral imaging, and biochemical markers of bone turnover. In the physical examination, there are 1 or 2 important tests which can give you an idea about the osteoporosis, and one of them is the wall occiput distance. If you ask the person to stand with the back touching the wall, in a normal individual who doesn't have kyphosis or abnormal kyphosis, I would say, because normal kyphosis is going to be there in the thoracic spine. But if you don't have abnormal kyphosis, your occiput can touch the wall. But if because of the osteoporosis you start developing abnormal kyphosis, then the distance from the wall to the occiput goes on increasing. And the second is a rib pelvic distance, wherein the collapse of the vertebrae in the lumbar spine brings the ribs closer to the iliac crest, and that distance will go on reducing. Another important thing is BMD. WHO has defined osteoporosis in terms of the BMD, and we are all aware that now there are many centers in almost all the developing cities who are doing DEXA scans by which we can understand what is the severity of osteoporosis. And this is normally measured in T-score. In a normal individual, the T-score will be up to -1. Anything beyond -1, from -1 to -2.5, you can call it as osteopenia. And anything beyond -2.5, you call it as osteoporosis. There are different sites which are used for measuring the BMD, and the BMD that is done by the DEXA machines, which are available in most of the places now, they are mainly doing the BMD in the area of hip and spine. So mainly in the axial skeleton and in the hip. And the different areas in hip which are measured for the BMD are Watt's triangle, the trochanter and the intertrochanteric region, plus the femoral neck, which is one of the most susceptible area for the fractures in elderly people. And in the lumbar spine, from L1 to L4 vertebrae, they are used for the understanding of severity of osteoporosis. There are two types of scores, T-score and Z-score, and as we go ahead, we will understand what is the difference between the two. But in addition to the DEXA scan, you are all aware that in number of hospitals, the BMD cams are arranged, and there the commonest modality which is used is the ultrasonography, wherein either lower end of the radius or the calcaneum is used to get idea about the extent of osteoporosis. But if you compare it with the DEXA scan or the other modality wherein you can get idea about the metacarpal thickness in a non-dominating hands X-ray, which can give you an idea on the radiological assessment about the severity of osteoporosis, the USG is far more inferior because it really cannot give you a very precise idea about the extent of osteoporosis. As far as the difference between T and Z score is concerned, the T score, it gives you the BMD of a patient, and that value is compared with that of a control subject who are at their peak bone BMD. That is a young patient who has got a normal BMD. So you compare it with a young patient's BMD in a given individual patient. But in a Z score, the patient's Z score is a BMD value compared with that of a person matched for age and sex. So that is the basic difference, and both are measured by the DEXA scan. As far as the vertebral imaging is concerned, vertebral fractures are assessed, which is a sign of impaired bone quality and strength, and that is a strong predictor of new vertebral and other fractures that the patient is likely to have because of osteoporosis. And this vertebral imaging is done, as we have seen in the first two tests, clinical tests, the wall to occiput and the ribs to the iliac bone. The lateral X-ray of the thoracic and lumbar spine done can give you an idea about these two clinical parameters, as well as this can give you idea about the vertebral imaging, giving you idea about the osteoporosis. And going ahead, presence of a single vertebral fracture gives you an idea that there is an increased risk of subsequent fractures by 5 folds in the vertebral column, and increased risk of hip and other fractures by 2 to 3 folds if there is one single vertebral fracture that you detect in imaging. There are some important biochemical markers of bone turnover. As we are aware, bone is a very dynamic tissue and there is a remodeling process going on all throughout the life. So there are some biochemical markers of bone remodeling which include resorption markers like serum C telopeptide and urinary N telopeptide, and there are some formation markers like serum bone specific alkaline phosphatase and osteocalcin. Evaluating the biochemical markers of bone tumor, bone turnover predicts the risk of fracture, rapidity of the bone loss, extent of fracture risk reduction after the treatment, and magnitude of BMD increase with whatever anti-osteoporosis treatment that you have given. WHO has found something called as a FRAX score or fracture risk assessment tool. FRAX tool developed by WHO is an important tool which can give you a FRAX algorithm to give you 10 years probability of fracture in that individual. And what are the various points which are considered by this WHO's FRAX scoring system? There are risk factors which are included, which include current age, gender, as we know that females are more prone for osteoporosis. The prior osteoporotic fracture, as we have seen that one single vertebral fracture can give you an idea about the extent of fractures that the person is likely to have. Femoral neck BMD, low BMI, oral glucocorticoids for more than 3 months, presence of rheumatoid arthritis, smoking, alcohol intake of more than 3 drinks per day, parental history of hip fractures, which gives you idea about the genetic background, and secondary causes of osteoporosis like type 1 diabetes, osteogenesis imperfecta in adults, and untreated long-standing hyperthyroidism, hypogonadism, and premature menopause. This is a calculation tool. Depending on these 10 factors, there is a questionnaire prepared by the WHO to get an idea about the susceptibility to the fracture in a given individual. And if you fill up this, then it can give you an idea about the FRAX score and the potential risk for any fracture. There are additional bone densitometry technologies which are used, which are not available in most of our places, is CT based absorptionometry, trabecular bone score, peripheral dual energy X-ray absorption, it's a further variation of DEXA scan, and quantitative ultrasound densitometry. After understanding the various investigation modalities, let's come to the management part. There are some general recommendations and some specific pharmacotherapy drugs that we are going to discuss about. The general recommendations are, as all of us know, supportive treatment with calcium and vitamin D. And there are some figures which have been calculated by National Osteoporosis Foundation that men after the age of 50 need about 100 milligrams of calcium every day, and females after the age of 51 they need 1200 milligrams of calcium every day, and the males after the age of 70 they need the same amount of 1200 milligrams of calcium. And the controlled clinical trials show that there is a definitely reduced risk of fractures with combination treatment with calcium and vitamin D. The normal recommended dose of vitamin D as a prophylactic treatment for the osteoporosis is about 1000 to 2000 units of vitamin D per day. You can take it either in the divided dose like 1000 to 2000 units every day, or you can take a loading dose of 60,000 units once in a month. And there are a number of preparations available in the market which you can take either in the form of tablets or the liquids. If the patient is found to be deficient in vitamin D, then you have to initially give a loading dose of 6 lakh units depending on how bad is the osteoporosis or how bad is the deficiency. You have to give 6 lakh units sometimes once in a week. And there are two schools of thought. Some people feel that you should give it injectable, But the general consensus now is that by giving injectable vitamin D, you don't achieve much benefit. So you can break the ampule of vitamin D and you can ask the patient to take it orally, and it is equally effective. The reason which is given is that vitamin D being a fat soluble vitamin, even if you inject by intramuscular route, for the absorption of that vitamin, it takes equally long time like an oral route. So there is no need of giving a painful oily injection which doesn't have any additional benefit. And there are a number of studies which have been done, including some important studies done by the All India Institute of Medical Sciences in Delhi. And now they recommend that vitamin D can be taken orally with equal effectiveness. So you have to start with loading dose if you have a deficiency, and then you can continue with 60,000 units once in a month. Regular weight bearing and muscle strengthening exercises, I think the importance of these exercises cannot be overemphasized. I think that is one of the most important thing which is recommended for even preventing osteoporosis or controlling the osteoporosis if you have started developing it. Then various modalities to prevent the fall. Then discontinuing tobacco and excessive intake of alcohol. As far as the pharmacotherapy is concerned, I think there are two important groups of drugs that we have to consider in addition to supplementation of vitamin D and calcium. And the two groups are anti-resorptive medicines and anabolic medicines. And amongst the anti-resorptive medicines, the commonest one which we all of us are using are bisphosphonates like alendronate, ibandronate, risedronate, and they have their own dosage schedules, like once in a year in a zolandronic acid you can give IV formulation, or ibandronate you can give once in a month 150 milligrams, or risedronate once in a week, like that. Calcitonin is another drug which is available in both injectable and the nasal spray form. And as an orthopedician, we recommend that this calcitonin can be used in osteoporotic fractures, especially the vertebral fractures. And it is found to be extremely effective in controlling the pain in addition to improving the osteoporosis. It works like a beautiful analgesic in many patients if you have given it in a nasal spray form. The estrogen agonist and antagonist like raloxifene and tissue selective estrogen complexes are different anti-resorptive medications which are used. And amongst the anabolic medications, the most popular one which is used quite liberally nowadays is teriparatide. Initially, when this drug was introduced into the market, the cost prohibition was a very major factor, and the per day treatment, per month treatment used to cost almost about 20 to 23,000 rupees. Now, number of Indian companies have come into the market, and the prices have come down to almost 4-5,000 rupees a month from 22,000 rupees. And the use of that drug has been quite extensively being done in the field of orthopedics as well as in endocrinology with very good results. But there are some new drugs which have come up, like denosumab. We as orthopedic surgeons, we know that this drug is used even in bone tumors like giant cell tumors, wherein the size of the tumor drastically reduces, and number of times this drug has been now used for the medical management of GCT in orthopedics. This is a fully human monoclonal antibody against rankle. It inhibits osteoclast mediated bone absorption and reduces incidence of fracture after 3 years of use in vertebral fractures by almost 68%, in hip fractures by 40%, and in non-vertebral fractures by about 20%. But the cost is again a very prohibiting factor as far as this drug is concerned. The other new agents are strontium granulate, and it promotes both bone formation as well as inhibits bone resorption. And the evidence shows that after 3 years of use, there is a 37% reduction in vertebral fractures and 14% reduction in non-vertebral fractures. And after 5 years of use, there is a 43% reduction in hip fractures and 24% reduction in vertebral fractures. As far as the anti-resorptive drugs are concerned, like the ones which we discussed, mainly the bisphosphonates, a word of caution, because there are a lot of orthopedic residents sitting here, that nowadays we are seeing some complications of extensive use of the bisphosphonates, and there are some fractures which we are coming across, especially the subtrochanteric region fractures, which are extremely resistant to the treatment, is one of the known complications that we are facing as orthopedicians because of the extensive use of the bisphosphonates. And these fractures just refuse to unite in spite of repetitive surgeries. The implants break because the fracture doesn't unite, and this has become one of the challenges in the field of orthopedic trauma now. So, a word of caution, you should not use it for more than 2 to 3 years, and you should keep a watch on the side effects of this particular drug. Next new drug that is introduced is anti-sclerostin antibodies. Sclerostin is an osteocyte-derived inhibitor of osteoblast action. So it inhibits, so any drug which is there to inhibit the sclerostin can promote the bone formation. So romosozumab is one of the drugs which is a new introduction, which is a humanized monoclonal antibody which inhibits sclerostin and has dual effect of promoting bone formation and inhibiting the bone resorption. So this drug also has got both the action, and significant improvement in the hip bone strength in population with high risk of fracture despite bisphosphonate therapy has been observed after the use of this drug. And patients transitioning from oral bisphosphonates to this new drug has shown consistent and significant gains in bone mass and estimated strength over the teriparatide. Now, in addition to the parathormone analog, this is a new drug which has come up, parathyroid hormone-related protein, and the drug is abaloparatide. Again, this is a drug which has to be self-administered subcutaneously like teriparatide, and this is a novel synthetic peptide analog of PTHRP. And this is an anabolic agent for postmenopausal osteoporosis. Cathepsin K inhibitors was another drug which was tried, but because of the high incidence of stroke after use of this drug, the use of this drug has been abandoned. After this medical management, as an orthopedic surgeon, I would like to touch upon some orthopedic aspects about the osteoporotic fractures. This is a different challenge because, as I said, the osteoporotic bones is something which is not going to behave like a normal bone, and there are some problems that we face in osteoporotic fractures, that these fractures can result because of very trivial trauma. There is much more comminution and crushing of the bone even with a trivial trauma, and if you try to fix these fractures, the implants have very poor hold because the cortex has become very thin and the cancellous bone also has become very porotic. There are very less number of trabeculae left. There is a tendency of collapse in this particular fracture. The implant can cut through very easily, and these fractures can go into delayed or non-unions. Because there is a poor muscle strength, the mobilization of these patients is very difficult, and usually these patients who are elderly, they have multiple comorbidities, medical comorbidities, which makes the situation more complex. So there are certain principles that we follow in treating these fractures, that as and when possible, orthopedicians will understand this particular terminology as load sharing and load bearing implants. Any implant which you put on a surface of the bone becomes a load bearing implant. So, say in a fractured neck of the femur, if you are using a DHS, dynamic hip screw, where there is a plate put on the outer surface of the femur, that becomes a load bearing implant. And if you have put in a nail which is in the intramedullary area, then that becomes a load sharing implant. So in osteoporotic bones, one should try and use load sharing implants. Try and do biological fixation so that you disturb the soft tissues and the circulation to the fractured area to minimum. As and when required, don't hesitate to accept some shortening by causing some compression or impaction so that the contact area improves and the chances of healing improve. You should use wide buttressing and long splintage if you have to use a surface implant. And if required, you should do augmentation either with the bone substitutes, bone grafts, or bone cement, by which you can improve the stability of your fixation. Or in situations wherein you feel that the bone is too porotic, you can think in terms of doing a replacement, or you can do shortening, especially in the upper limb fractures. Some examples: this kind of a comminuted fracture in a tibia, if you try to fix all the fracture pieces, you will devitalize the entire bone and the bone is already porotic. So in this situation, you can go for minimally invasive technique and do a biological fixation, use minimum screws, use a long implant. And how long should be the plate? Any orthopedic resident who can answer? If you are using a lock plate, how long should be the plate? What is the normal formula which is followed? What should be the length of a plate? Loud? 3 times of what? Not fracture fragment, the length of the fracture. If it's a spiral fracture which is going, say, about 3 to 4 holes of a plate, then you should have at least 9 hole long plate to fix that particular fracture. And you should not put all the screws into all the holes, so the density of the screws should be less. That is what you see in this fixation. Or you should use a long splintage. This is a supramalleolar fracture, but you can see you have used a long plate and the distance of the screws from the fracture site is considerably long. Or you can do augmentation, as I said, with either bone grafts or resorbable bone substitutes or calcium phosphate or hydroxyapatite. You can use the screws which are hydroxyapatite coated in porotic bones so that they can have a better hold. You can use bone cement, or you can inject the platelet rich plasma or bone marrow, or you can use bone morphogenic proteins. Or you can use non-invasive techniques like electromagnetic stimulation or low pulse ultrasound. For the people who are not from orthopedic field, this is a new implant which is basically developed for the porotic fractures. These are the plates and screws which are called as locking plates, wherein if you see, the plate hole is what is called as a combi hole. It has got 2 parts. One part is having threads inside and the other part is a non-threaded part. And if you see the design of the screws on top, the left one shows that the head is without any threads, but the right one shows that the screw head also has got threads. So the principle is that in a porotic bone, the screw doesn't have good hold into the bone alone. So what you do is you put a plate which has got threaded holes and you put a screw which has got threads on the head of the screw, so that the screw not only takes hold into the bone, but it takes hold into the plate itself. So the chances of the screws tracking out is minimized. These plates can be used as a dynamic compression plates also, because this hole is a combination hole. most of these plates are anatomically shaped, so there is no need of pre-bending, and this can work as an internal external fixator. There are now some papers published in the Chinese literature wherein they are using these plates on top of the skin, that is extracutaneous fixation, and you can pass the screws through the plate and it can work as an external fixator itself. There are about 156 patients tried with this kind of modality, and in the Chinese journals they have published this paper and these cases that they have very good results. So these are some examples of these lock plates in porotic bones. This is an apparent humerus fracture in a porotic male 60-year patient, and you can use this lock plate with multiple screws. But this particular situation, you don't have to use less screws, but you try to give best possible hold into the head. Another one, female with very porotic bones, and you can use this lock plate of a different design to give a good stable fixation. This was a almost 76-year-old lady. Normally one would think of doing a replacement of fracture neck femur, but because this was an impacted fracture, we decided to do a fixation with cancellous screws and achieve more impaction and compression, and this healed very well. Or in a situation like this where there is a porotic bone and there is a segmental fracture, you can use an intramedullary implant which can give you a much better and stable fixation. Another one with a very porotic bone in a femur, and you can use an intramedullary nail with fixation into the neck. This is called as a PFN plus bone grafts, and it went to a excellent healing. Another one where there was a porotic bone in the trochanteric area and there was a subtrochanteric fracture and a proximal femoral nail used. Some examples of augmentation. This is a bipolar prosthesis in a porotic patient wherein we have used bone cement. Another one with a bone cement. This was a porotic femur where the implant had cut through and it had started eroding the acetabulum. So we had to opt for a total hip replacement in this situation. Vertebral fractures are one of the commonest fractures in these porotic patients, and there are a number of things which have come up to treat these fractures, and one of them wherein there is a resistant pain is an excellent modality called as vertebroplasty. You can do different fixations also, but then if you have to do fixation, you have to do fixation with the hydroxyapatite coating screws used in the pedicle, or sometimes you have to use bone cement which has to be injected through the pedicle, and then you can put the screws so that they have a good hold. But this is a technique of strengthening the collapsed bone by injecting a bone cement which is of a different quality, which remains liquid for almost about 20 minutes. And this procedure can be done under the image intensifier under local anesthesia with a completely conscious patient, and believe me, it gives excellent relief of pain. The patient who is unable to walk and sit, you do injection of this bone cement in the compressed vertebrae, and the patient can literally walk down from the table without pain within next 15-20 minutes time. So an excellent modality to relieve the pain and give strength to the compressed vertebrae. This is an example. You can see at 3 levels we have injected bone cement into this through a needle, and the patient is under local anesthesia. If your needle by chance takes a little wrong path and tries to go near the nerve root, the patient himself will tell you, I am getting tingling or pain near the nerve, so you can change the path and you can do this procedure. Anybody who is familiar with doing pedicular screw fixations, I think you can easily learn this technique of vertebroplasty, and it's one of the excellent modalities for this porotic vertebral collapse. Another one which we have done. So friends, The take-home message at the end is that osteoporosis is an increasing problem with the elderly population. The investigation modalities to quantify the porosis are available and they should be used. The medical treatment should be planned as per the severity of osteoporosis, and the proper surgical modality of treatment can change the prognosis of these porotic patients. The timely detection and prevention is a key to conquer this disabling condition, and with the present modalities of diagnostic facilities that we have, I think we shouldn't allow them to go into severe osteoporosis, prevent the porosis and prevent all the complications. I thank you very much for your patient listening. Thank you.
Thank you so much, sir, for the excellent deliberation. And I would like to request the audience if you have any query to ask to Dr. Vijay Kakatkar. Yeah.
So regarding Therapeutic, for how much duration or we can give the Therapeutic injection? For how many months or how many weeks?
Well, the standard recommendation is that you should give it for minimum 1 year, and sometimes you should assess the BMD score, and if you feel that at the end of 1 year there is not satisfactory improvement, you can extend it up to 1.5 years also. Nowadays, this is used even for fracture healing in osteoporotic bones, and in that condition, you can use it for just about 3 months. But if you are using it for correction of osteoporosis, minimum period is 1 year.
But can we use it again after few years or something?
Yes, you can use it. For reuse, there are not many papers which are available, but I think if you take a gap of a year or so, you should be able to use it. Same way for the bisphosphonates also, there are a number of papers published wherein they recommend cyclical use of bisphosphonates so as to prevent this disaster of this bisphosphonate induced fractures. Rebound osteoporosis, yes.